Thank you for joining us this morning. We're going to get started on time. Our speaker has a plane to catch at the end of our hour, so welcome very much. I'm Lisa Chamberlain in General Pediatrics, and on behalf of the Crowley family, I welcome you to the Crowley Lectureship. A few announcements before we get started. Upcoming grand rounds. Next week we have Dr. Hildenbrandt from Harvard Medical School coming to talk to us about nephrotic syndrome. Following that, we're going to hear from our very own Bonnie Halpern-Felsher, and she's, if you haven't seen her on the news or anywhere else, will be talking to us about the vaping phenomenon, what it is, why it happened, and what we can do about it. So that should be high importance talk, something confronting all of us. And then on November 8th, we'll be hearing from Dr. Patrick Konchitnak from the University of Pittsburgh, talking about cardiac arrest and traumatic brain injury. We have a new system for keeping track of your attendance at grand rounds. It involves your phone. If you're struggling with that at all, please talk to Serena outside. Basically involves registering your phone number with our system, and then you just text the lecture number that you are attending, and all of your CME will be automatically recorded. So please let us know if you need any help with that. Wanted to do a quick reminder about the Stanford Pediatrics Engage program. This is a teaching seminar so that we can strengthen some of our teaching skills. The couple things coming up, Michelle Brooks will be leading us to talk about different leadership styles, and Christopher Stave, who is an amazing medical librarian, will be helping us with how to do thoughtful lit searches. Finally, want to make sure this is on everyone's calendar, our second annual research symposium coming up Friday, November 15th. And so that grand rounds will be over in Berg Hall, where our keynote speaker will be the head of the NICHD, Diana Bianchi. So that'll be a red letter day. Please make sure to note that. So that's it for our announcements. I'm very excited to talk to you today about our Crowley lecture. So this lectureship was established by Dr. Crowley, who was a professor of surgery here at Stanford many years ago. He was a natural leader, had office roles in the dean's office, and was the chairman of the board of our children's hospital as it was in its previous iteration. He worked with Dr. Irv Schulman at the time and Lucille Packard to establish this children's hospital where we sit today. And towards the end of his career, he approached Dr. Harvey Cohen and said that he had some funds and would like to establish something that would have an ongoing way to contribute to our community. And he wanted to honor innovation. And in that spirit, he established the Crowley Lectureship to honor those who are innovative thinkers. And I can't think of a better person to join us to talk about that in that spirit today than Dr. Anna Lembke. Dr. Lembke did her training. Well, I should note first, we learned last night at dinner that she was born in Phoenix, Arizona, and in the same hospital that I was born in. So that was very exciting discovery for both of us. Different years, just slightly, but right together. So she was not there for long, went onward and did her undergraduate training at Yale, did her residency here at Stanford, medical school at Stanford, and then a psychiatric residency at Stanford, as well as a fellowship. In addition to pages and pages and pages of papers and honors and awards that she's had, I was really struck by how many talks she's given. She's been zigzagging this country and on national media talking about what has become one of the biggest epidemics that we're facing. I want to read to you briefly about the book that you should all have received a copy of, which thank you for the generosity of that to the Crowley family. Dr. Lembke was one of the first in the medical community to sound the alarm regarding the opioid overprescribing and the opioid epidemic. In 2016, she published her best-selling book on the prescription drug epidemic, Drug Dealer, How Doctors Were Duped, Patients Got Hooked, and Why It Is So Important to Stop, published by Johns Hopkins University. This book combines case studies with public policy, cultural anthropology, and neuroscience to explore the complex relationship between doctors and patients around prescribing and controlling drugs. So I've seen her speak on main campus. We are in for such a treat today. So please join me in welcoming Dr. Lembke.
Can everybody hear me okay in the back? It's all right? Okay, great. Well, it's my really great honor to be here today to talk to all of you. And I'm especially honored to be part of this distinguished Crowley lecture series. My biggest challenge is going to be getting through everything I want to get to in the time that I have. I have been retained as a medical expert witness in the federal multi-district litigation against opioid manufacturers, distributors, and pharmacies. These are the learning objectives. First, I want to talk about what happened. How has opioid prescribing changed between about 1980 and today? Then I want to get into how it happened, exploring a lot of different factors, or what I call the invisible forces inside of medicine that are driving opioid overprescribing. And then finally, what we can do about it now. So first of all, let's take a look back at what happened. Prior to 1980, doctors were reluctant to prescribe opioids because they were afraid that their patients would get addicted, and for good reason. This country had seen 2 prior severe opioid epidemics. But there was also recognition that we in the medical profession were not doing a very good job helping patients with pain. The 80s was also the advent of the hospice movement. Again, this idea that we could do more and possibly even use opioids more liberally to help people in extremis and at the very end of life. Unfortunately, what started as a very good and well-intentioned movement inside of medicine ultimately morphed into any patient who walked in to see a doctor and said, I have pain, would get opioids dispensed just like from a vending machine. And it's very clear today in retrospect that increased opioid prescribing was directly causal in the creation of today's very severe opioid epidemic. Opioid prescribing quadrupled between the 1990s and 2012, as did opioid-related overdose deaths, as well as a stark increase in the number of people addicted. This is a picture that was taken by the Ohio Police Department. These individuals were pulled over on the side of the road. The 2 in the front are the grandmother and the grandmother's friend of the boy in the back. Neither is deceased. Both are unconscious as a result of opioid use. I show this just to emphasize the multi-generational trauma wrought by addiction. Note the watchful waiting of the child in the background, the typical consequence of children who grow up with addicted caregivers. So who's prescribing all of these opioids? Well, it's very easy to point to pill mill doctors, those who have lost their moral compass, willfully exchanging prescriptions for cash. But to just look at those pill mill doctors working in disreputable pain clinics is to really misunderstand the origins of this epidemic. This epidemic arose because well-intentioned, compassionate doctors like you and me increased opioid prescribing. This is a study that we published in JAMA Internal Medicine looking at who prescribes opioids in this country. We used a Medicare 2013 database, so it's a nationally representative sample. What we found is that by volume, family medicine and internal medicine doctors prescribe the most opioids in this country, which makes sense because there are more of them. By specific specialty, it's pain specialists. Again, that makes sense that pain specialists by specialty would be prescribing more opioids. But really, our most salient finding here was that opioid prescribing is well distributed across multiple specialties. There is not a small subset of prolific prescribers driving this epidemic. There was a paradigm shift inside of medicine to change the way that we prescribe opioids. This is from the National Survey of Drug Use and Health. I want to highlight here that that big yellow circle is the more than 11 million people in 2016 who were misusing prescription opioids. You'll note that in comparison to the small orange circle, the approximately 1 million people who are using heroin. Heroin and illicit opioids are a huge problem. There is appropriately a large amount of press attention on that, especially now. But do keep in mind that prescription opioid misuse, which is the stepping stone to prescription opioid addiction, is a ginormous problem in this country. Where are people who are misusing prescription opioids getting their opioids? Again, from the National Survey of Drug Use and Health, you'll see that blue section is the approximately 35% of misusing individuals who gets it from a single prescriber. And the larger portion, the 55%, is individuals who get their prescription opioids from a friend or a family member. I want to highlight a really underappreciated phenomenon in medicine, which is that there is a large segment of individuals who have severe pain, who are prescribed opioids, who use part of their prescription and give or sell the other part away. So this is not black and white, the people who are taking it legitimately as prescribed and those who are diverting it. This is a big, they're often one and the same. Okay, so where are we now in terms of the opioid overprescribing problem? Here's the good news. Opioid prescribing peaked around 2012 and has decreased approximately 29% since that time. But I want to show you some data to really emphasize the enormous geographic variability in terms of opioid prescribing. These are CDC data. At the peak of opioid prescribing in 2012, we were writing 81 opioid prescriptions per 100 persons in the United States. By 2017, we were writing 59 opioid prescriptions per 100 persons in the United States. So that's great progress. But look at these data. The highest state average in 2017, the last year for which we have reliable numbers, in Alabama, they were still writing 107 opioid prescriptions per 100 persons. And there is enormous county-to-county variability, even within single states. Let me highlight this with a heat map. The dark red is more opioid prescribing, approximately more than 107 opioid prescriptions per 100 persons. You'll notice that the southeastern United States predominates here, and this is in 2012, the peak of prescribing. This is from 2017, lots of improvement, but again, we have a definite region in the southeastern part of the United States where opioid prescribing continues to be very high, higher than the national average at the 2012 peak. And then if you look at this county by county state, you'll notice the variability. Even California, Nevada, Oregon, there are counties that continue to prescribe at very high rates. Also, please do keep in mind that although opioid prescribing has decreased since its peak in 2012, we are still, as a country, prescribing 4 times as many opioids approximately as most European countries and more than 10 times as many opioids as Japan, despite comparable needs for analgesia and comparable aging populations. So we're way off scale with other developed countries. Also, there is what I have described as a hidden benzodiazepine epidemic, and I have particular concerns that as we're pulling people off of opioids, we're transitioning them to benzodiazepines. Particularly in the psychiatric community, benzodiazepines are woefully overprescribed. Okay, so where does that leave us? Prescribing has gone down. Does that mean opioid overdose deaths have gone down? Unfortunately, no. Instead, what we've seen is an increase in opioid overdose-related deaths. And how do we understand that? Well, this is broken out by opioids. This is not, doesn't have fentanyl specifically broken out, but you will see that heroin surpassed prescription opioid-related deaths right around 2014, 2015. So that purple line that kind of plateaus, that's prescription opioid-related deaths. It's important to note that in 2017, of the 47,000 opioid-related deaths, 17,000 were still related to prescription opioids. So the problem has leveled off, but it hasn't gone away. Importantly, though, now what we're seeing is the second and third waves, a huge increase in heroin and illicit fentanyl-related overdose deaths. So what's going on with that? In part, we do believe that because of the retraction in prescribing, we have individuals who relied on getting their opioids from prescribers who have turned to illicit sources. There's some evidence to suggest that patients are being turned away, and certainly anecdotally I have seen that in my practice, because doctors no longer want to prescribe opioids. It's too dangerous for them to do that. But do keep in mind that that is probably not the main driver of this transition to illicit opioids. The main driver is probably what's called the gateway effect, that individuals are exposed to opioids through a prescription, even very transiently, and then go and seek out illicit sources. We do know that most of the people dying from heroin and illicit fentanyl are younger people, people in their teens and 20s. So this is just from Lagasetti, JAMA Open, published this year, showing that they had Confederates who were pretending to be a family member of a person with chronic pain on opioids, called primary care clinics in the state of Michigan, trying to find a provider, and 40% of those individuals were turned away. In other words, we now have this cohort of what's been called opioid refugees, individuals who have previously been prescribed in high volume, wandering from clinic to clinic, unable to find anybody to treat them. The FDA issued a warning on abrupt discontinuation because what's happening now is doctors are suddenly refusing to prescribe and patients are ending up in the emergency room in severe opioid withdrawal. But really important, do keep in mind this gateway effect. This is probably not primarily driven, again, by patients who are on chronic opioids who suddenly can't find a treatment provider, rather by individuals who have been exposed through a brief medical interaction and then get a taste for opioids, so to speak, and then go on to try illicit sources. This is a very sort of important data point by Cicero et al. In JAMA 2014, showing that in the 1960s, 80% of heroin users reported that they started with heroin, whereas by 2000, 75% of heroin users reported that they started with a prescription painkiller. So the journey is really different today. This is by our very own Alan Schroeder, showing that if you look at 16 to 25-year-olds who are exposed to a single opioid prescription through a dentist, what you find is that 6% of them will be diagnosed with an opioid use disorder within that year. And very interestingly, 10% of them 10% of females will go on to be diagnosed with an opioid use disorder in that year. This is a really important point because it shows how that single brief exposure, let's say through a wisdom tooth extraction, can lead to opioid use disorder. So how did this happen? I really want to take the next little bit and take a closer look inside of medicine so we can understand how we got to where we are today. And the thesis that I'll be making is that the opioid epidemic today is really the canary in the coal mine for a faltering healthcare system, that in fact opioids became the solution not to patients' problems, but to doctors' problems. So in order to do that, let's first start out by taking a look at who is the compassionate doctor. I would argue that the compassionate doctor is first and foremost somebody who is innately a pleaser. We also tend to be people who figure out complex systems like the school system to get to the top of our class to be able to get into medical school or nursing school. And by the way, when I use the term doctor here, I'm using it loosely to include anybody who interfaces around prescriptions and patients. So we're good at figuring out systems. We're kind of honestly natural codependents. We like to be needed and we like to help people. At the same time, we choose medicine because we're responding to a higher calling, right? We want to save lives. We want to alleviate suffering. We really go in with a kind of a mission-driven goal. As we go through our medical training, we're heavily socialized to empathize with our patients, to put ourselves in their shoes. We are not trained in how to deal with patients who may be lying to us or manipulating us. And I would also argue that what keeps us going on a day-to-day basis throughout our careers is mutually affectionate relationships. Despite all of the prior authorizations and insurance calls and pharmacy calls and politics, I know that I get up every morning and go to work because I'm looking for that moment when I will have that interaction with a patient that confirms my identity as a healer. The patient expresses gratitude for the work that I've done, and I feel like I've fulfilled my purpose. This is really, really important, and I think it's especially salient for those individuals who deal with children and that desire to want to be a helper and alleviate a child's suffering. But this also makes the dynamic around prescription opioid misuse especially complex, because when we enter into challenging whether or not that patient is using the opioid appropriately, or we suggest that maybe that individual needs to come off of the opioid, it really interferes with that mutually affectionate relationship, at least so far, because we haven't learned the skills to manage it. Okay, now I want to shift the lens a little bit and talk briefly about what motivates the drug-seeking patient. And by here, I'm talking about patients who come to us seeking help for their pain, and in the process of pain treatment, end up getting addicted to or just dependent on the opioids. In order to understand the drug-seeking patient, it's really important, in my mind, to understand some basic neurobiology about addiction. And one of the ways that I think about addiction and teach it to others is to kind of condense it into this extended metaphor. So I'm going to take 3 minutes to give you the last 50 years of neuroscience of addiction in a very simplified form. One of the interesting findings in the neuroscience of addiction in the last 50 years is that pleasure and pain are co-located. So the same area of the brain that processes pleasure also processes pain, and pleasure and pain work like a balance, as pictured here. When I experience pleasure, my balance tips one way. When I experience pain, my balance tips the other way. So I like chocolate. So when I have a piece of chocolate, it goes on my pleasure side. I get a little tip to that side, little dopamine release in my pleasure pathway. But there is a very important rule governing that balance, and that is that the balance wants to stay level. So it goes through a process called neuroadaptation, where it changes in response to having seen that drug. For example, it downregulates my dopamine chocolate receptors. It downregulates my chocolate dopamine. I imagine that as little gremlins hopping up on the pain side of the balance to bring it level again. The thing about those gremlins, though, is they like it on the balance and they don't want to hop off right away. So they stay on until the balance has been tipped over to the side of pain and equal and opposite amount. And then they hop off and the balance is level again. So how do I experience that? That's that moment of wanting a second piece of chocolate. Again, it's transient. If I wait long enough, the gremlins hop off and my balance is level again. One of the most important things that distinguishes substances that are addictive and substances that are not are how much they tip the balance. So if I take Vicodin, I get a great big shift to the side of pleasure, a huge dopamine release. That little chocolate gremlin will not bring my balance level again. I need a great big Arnold Schwarzenegger gremlin to bring me level, but he stays on, so I tip to the side of pain. That is opioid withdrawal. If I wait long enough, the neuroadaptation resolves itself and my balance is level again. But imagine the scenario of someone in pain who, by the way, is already starting out with the balance tipped to the side of pain, right? Because they're experiencing physical pain, emotional pain, whatever it is. Then you give them Vicodin, not just one time, but for days to weeks to months to years. Now I have a whole host of gremlins on the pain side of my balance to bring it level again, enough to fill this entire room. What happens when that individual stops taking that opioid? The balance crashes to the side of pain, and it doesn't resolve in a short amount of time. It continues to be tipped to the side of pain even after acute opioid physical withdrawal has resolved. And this is what drives drug seeking. This is what causes people who have become addicted to return to drug use even after a sustained period of abstinence. They're not walking around with a level balance. They're walking around irritable, depressed, anxious, can't sleep, and most importantly, intensely craving that drug. Next, I'm going to talk briefly about strategies that patients use to manipulate certain types of prescriptions from their doctors. These are meant to be memorable and not denigrating. And I'll just launch right in. So this is the senator technique. These are the senator of the patients who use the filibuster technique. They wait to the last 30 seconds of the appointment to ask for a refill because they know it's easier and more timely to say yes in the last 30 seconds than to get off schedule explaining why that person can't have the prescription. The sycophant is the patient who tells you what a wonderful doctor you are, how much better you are than their other doctor. I know when I was early in my career, I loved to hear that, but as I moved along in the process, it made the hair on the back of my neck stand up, just realizing that I was soon probably to be the next on the chopping block. The exhibitionist, these are patients who demonstrate pain in the room with the doctor, often writhing, in my experience, undressing, showing their scars. This is not to say that these individuals are not in pain, but it's the demonstration of pain to get a certain type of prescription. The dynamic duo, this is often the patient and a significant other. In my experience, it's the mother and the patient. The mother's crying, the patient's demonstrating their pain. Very hard to say no when you are dealing with two individuals who are in distress. The city mouse and the country mouse. So the city mouse is the very savvy pain patient or patient seeking opioids who walks into the ED and says they're allergic to all pain medicine except for IV dilaudid push with a Benadryl chaser. The country mouse is the sort of fresh-faced naive who you would never imagine has been drug seeking. Check the prescription drug monitoring database and find out you're the fourth doctor that day to have written the same prescription. This is a very common theme. These are patients who lose their prescription, who lose their medication. Water seems to be a prevailing metaphor here. It went and bottom of my fishing boat. It fell in the washing machine, in the toilet, in the washing machine, went through the rinse cycle. The weekender, this is a common strategy, calling in on the evenings or weekends when you know your regular doctor won't be there and that the harried resident on call will do anything to get off the phone to deal with their other patients. The twin, these are often other healthcare professionals, individuals who also work in the system, who drop names, we know the same people. And then of course the doctor shopper, these are patients who go around to the same or the multiple providers looking for the same or a similar prescription. The bully, this is probably the most tried and true tactic here at Stanford. It takes the form of them calling patient relations, complaining about the care that we are giving, or threatening to sue. So we've talked a little bit about what drives the compassionate doctor, what drives the drug-seeking patient, but these individuals are not operating in a vacuum. They're working in this increasingly complex healthcare system, and there are a lot of invisible forces that are driving overprescribing. I'd like to quickly go through those invisible forces. The first is the pharmaceutical industry, which has really co-opted big medicine, Trojan horse style, and infiltrated the very same watchdog organizations that were meant to protect patient consumers and make this paradigm shift so that we started using opioids liberally for minor and chronic pain conditions. Those watchdog organizations include the Federation of State Medical Boards, the Joint Commission, which made pain a vital sign, thought leaders, CME, etc. In doing so, they were able to perpetrate certain myths about opioid prescribing, which I learned in the 90s in my medical training and continues on in some form to this day. So I'd like to just take a moment to dispel these myths. I have a lot more papers if you want more references. I don't have time to go through everything. But the first myth is that opioids work for chronic pain. In fact, there are no placebo-controlled trials longer than 12 to 16 weeks showing benefit of opioids compared to placebo. Opioids work great for acute pain. They do not work, at least based on the evidence, for chronic pain. Not only that, they can actually make pain worse over time through a process called opioid-induced hyperalgesia. What does the evidence really say about pain efficacy? Again, no reliable evidence. You should know about the SPACE trial. This took primary care opioid-naive patients, took half of them on opioids, the other half on Tylenol, ibuprofen, etc., and found no difference after 12 months in pain efficacy in Tylenol, etc., versus opioids, but a lot more side effects in patients who had opioids. This is a very interesting article, a meta-analysis by Busey et al., published in JAMA, which defined a minimally important clinical difference. They said on that 1 to 10 scale, if a patient has to endorse more than 1 centimeter improvement for there to be a minimally important difference, and they found in their meta-analysis that looking at high-quality studies, there was no clinically significant difference between opioids and placebo. Now, here's a very strange thing. In their abstract, in the conclusions, they said opioid use was associated with statistically significant but small improvements in pain and physical functioning. That statement does not actually reflect the findings of their study. This is a very common phenomenon in this literature. So I urge you not to just read the abstracts of these articles, but actually to read the articles themselves, and you will be surprised at how often you will see a discrepancy between what is endorsed in the abstract conclusion for lots of different reasons and what is actually shown by the evidence of that study itself. Myth number 2, no dose is too high, no duration too long. In fact, that is completely false. What the evidence really says is that opioids taken in high doses for long duration harm patients. This is just one of many studies by Bonner et al. Showing a dose-dependent effect on the risk of suicide, the risk increasing at each dose interval. And importantly, this includes cancer patients. So opioids are indifferent to the cause of the pain. Cancer patients do not have some sort of rarefied place in this problem. It's of course devastating to have pain for any reason, but I think we really have to be aware that the chronic non-cancer pain, that non-cancer part, is also a myth. Myth number 3, less than 1% will get addicted, as if the prescription pad conferred some sort of magic halo effect. And those who appear as if they're getting addicted are not, in fact, really addicted. They're what's called pseudo-addicted. This was picked up by Purdue Pharma and others and propagated across the medical education. Here's what the evidence really says about addiction risk. 1 in 4 patients with chronic pain prescribed an opioid will develop an opioid use disorder, and 1 in 10 will develop a severe opioid use disorder. This is a timeline showing studies finding prevalence rates for opioid addiction in chronic pain patients. And you'll see well before the 1990s marketing campaign of Purdue Pharma and others we had evidence showing a risk of addiction in chronic pain patients prescribed opioids, which was sort of forgotten about. It was like a collective amnesia. Probably the most reliable recent source is Voles et al., again, showing that about 1 in 4 patients will develop a mild opioid use disorder or a misuse disorder, and about 12% will become addicted. Myth number 4, dependence is benign and easily reversible. The drug companies love this, and in fact, they were involved in changing the criteria from in the DSM-4 to DSM-5 to take dependence out as its own separate category, different from addiction. The idea being that that's a common thing and it's no big deal. In fact, we now have a huge cohort, 10 million plus of chronic pain patients dependent on opioids who do not meet addiction criteria, who are struggling to get off, and we need care for those people. Dependence is no joke. Here are all the studies that have come out recently, including Harbaugh et al., just third from the bottom, showing the risk of persistent use in opioid-naive individuals after a very brief exposure related to a surgery or a medical procedure. And for you all in the pediatric community, 5% of opioid-naive kids who are exposed to an opioid, just exposed as a result of a medical procedure, will go on to develop persistent opioid use. Now, that's not opioid use disorder, but it means they're still on opioids a year later and they should have come off. And of course, the longer you're on opioids and the higher the dose, the higher the risk. Here's what the evidence really says about tapering-dependent patients. Tapering improves pain and other healthcare outcomes. Abrupt discontinuation is not tapering. You will read articles showing people ending up in emergency rooms because their opioids were stopped in one day. That is not good medicine. But tapering patients slowly in an opioid-centered way, if they're taking opioids in a scenario where the risks outweigh the benefits, is good medicine. Tapering improves opioid pain. Again, these are 2 studies, especially the Frank meta-analysis, and tapering opioids, it looks like, may also improve depression. Myth number 5, risky patients can be screened out. We know about many different risk factors for developing addiction: poverty, unemployment, a biological parent or grandparent who has addiction, co-occurring mental illness. It makes theoretical sense that if we screen patients for those items, we might be able to predict who would get addicted to the opioids we prescribe and who wouldn't. It turns out we don't have good screening tools. We are not able to do that. We are not good at that. Here's what the evidence really says. Existing screening tools are no better than chance. I really want to highlight the opioid risk tool, which has commonly been used in papers by Lynn Webster. It has recently been invalidated, shown to be no better than chance in predicting who will and who will not get addicted to the opioids we are prescribing. This really important paper by Edlin et al., showing that dose and duration of prescribed opioids are the biggest risk factor for predicting who will develop an opioid addiction, even bigger than the classic risk factors like a co-occurring mental health diagnosis, prior alcohol use, etc. And this is just an article by Fleming et al. Showing that part of the reason that the opioid risk tool and other screening tools don't work is because patients lie. Why do patients lie? Because they're addicted. That's one of the signs and symptoms of being addicted. This is just a study showing that 46% of patients with positive toxicology denied illicit drug use, which was found on toxicology. Just to review the myths of opioids, number 1, opioids work for chronic pain, no dose is too high, less than 1% get addicted, dependence is benign, and screening patients reduces risk. None of those things are true. Okay, so let's put Big Pharma aside and talk about another invisible force driving overprescribing, what I call the Toyota-ization of medicine. What's happened in the last 30 years is that there's been a mass migration out of physician-owned practice into large integrated healthcare centers, such that we are now salaried employees for large systems. This is just a study from the New England Journal showing this transition. More than 70% of physicians now are salaried employees. And as a result, we now practice protocolized medicine. This is top-down medicine, and it includes many inherent pressures, including pressures to palliate pain, to prescribe pills, perform procedures, protect privacy, and most of all, to please our patients. We have become de facto waiters. This is a online screening of my abilities as a doctor. My then 13-year-old son found this online, called me over, and he said, "Mom, is this you?" He was really distressed. And I looked at it and I said, "Oh, okay, I think that is me," because at the bottom, this is what Corey had to say about me. provides the kind of care that will make you wish you had never sought help in the first place. Wrong diagnosis, wrong medication. In some cases, this can be terrible. Seek help from someone else. I was naturally mortified. This is a huge driver of how doctors prescribe opioid. I have been all around the country in the last 3 years talking to doctors, and invariably I have doctors come up to me afterwards and say, I'll prescribe fewer opioids when you can promise me that I'll still get good ratings on my patient satisfaction surveys. These are directly linked to professional advancement, directly linked to salary. At the same time, there's no evidence that patient satisfaction surveys improve clinical care or pain outcomes. In fact, this data point shows that patients who like their doctors more are more likely to die, even when controlling for severity. So not good. Now, the good news for me in this instance is my son did come out a few minutes later. He said, "Don't worry, Mom, I just gave you 4 out of 4 stars." Twice. Another invisible force driving overprescribing is the medicalization of poverty. What do I mean by that? I mean, in the last 30 years, we healthcare providers are increasingly asked to care not just for our patients' biomedical problems, but also for their psychosocial, spiritual, and socioeconomic problems. But we are not given the tools to actually care for those problems, so we biomedicalize problems consciously or otherwise that are not in fact medical, and then what do? We prescribe a pill. In fact, the poor are treated differently when it comes to opioid prescribing. People receiving Medicaid are prescribed opioids at twice the rate of non-Medicaid patients, and die at 6 times the rate of non-Medicaid patients. I told you that opioid prescribing is going down, but if you look at the Medicaid population, it's only now going down in the last couple of years. It was rising continually, even as other private insurance patients were having their opioids decreased. Another invisible force driving overprescribing is narratives about pain. So pain is a biopsychosocial disorder. The narratives we construct about pain impact our experience of pain. And the current narrative that we have now inside and outside medicine around pain is that pain in any form is dangerous. That the individual who experiences either emotional or physical pain will be left with a kind of psychic scar that sets them up for pain in the future. The classic example is post-traumatic stress disorder. It is very important to recognize this is an entirely modern phenomenon. 150 years ago, doctors actually thought that pain was salutary. They believed that pain during surgery boosted the cardiovascular response, boosted the immune response. We no longer have any paradigm to think of pain that way anymore. I will just suggest as a data point, this very fascinating study by Henry Knowles Beecher, who studied soldiers on the front line in World War II who experienced horrible injuries, amputations, their guts spilling out. 2/3 of those individuals experienced 0 pain in the immediate aftermath of their injury, and Beecher ultimately concluded that that was because they knew the injury meant that they were going home. Again, very important contextualization of pain. We have trained 3 generations of our patients to focus on their pain, to give it a number, and to get really anxious about it. So doctors and patients are caught between a prescription and a hard place. What does that do? It generates a lot of anxiety. Then they enlist their defense mechanisms. Defense mechanisms are unconscious strategies we utilize to get rid of negative and intolerable emotions. The most obvious one is denial. Just say that's not happening. Projection is when I take my negative emotion and I put it on somebody else because I don't want to own it. When I get mad at the patient who is drug seeking. Splitting is when I divide things into good and all bad. So patients do this to us. They're the good doctors and the bad doctors. And by the way, we do this with our patients, where we divide them into the good patients and the bad patients. Good patients are ones that make me feel like I know what I'm doing, take about 10 minutes, and they bring me chocolate at Christmas time. Bad patients are patients with addiction. Passive aggression, the most common form of this primitive defense mechanism, is procrastination. These are the patients I put off. I'm rounding in the hospital. I spend 5 minutes instead of the 20 minutes that they really need. When they say, when should I come back, doctor? I said, 3 months is fine, or make it 6. So what happens, very briefly, and I see I'm running out of time, but I really want to get these videos in. What happens when the compassionate doctor and the drug-seeking patient get a room? This is a dramatic reenactment.
Well, this is great. We talked about your diabetes, we talked about your hypertension. I put in the referral for the nutritionist, And you're doing great. So I will see you next time,
Gosh,
okay?
you know, you are so good, Doctor. Thank you so much.
Oh, my
I just
pleasure.
love working with you. You know, you're so much better than my old doctor. You take time to explain everything to me. I really appreciate that. I filled out one of those surveys out of the front desk. They give you the patient evaluation thing, you know. I just glowed about you. I just love having you for my doctor. Just one more thing before I go. Could you refill my oxycodone? I know I'm a couple of days early with it, but my family was in town this week, and oh gosh, my fibromyalgia has really been acting up. You know, I think it's probably because of all the extra cooking and cleaning I had to do while the kids were in town, you know.
Okay. Yeah, I'm not sure that's a good idea. I think I just gave you an early refill last month. I mean, I'm not sure. I'd have to check the computer.
No, I don't think so. I don't mean to bother you. I'm really sorry. I know you're super busy. It's just that my pain has been so bad, you know?
Yeah, I mean, I hear you about the pain. It's just that, you know, you're at really high doses, and we've gone up a lot on the doses, and I'm starting to think, you know, maybe I need to refer you to a pain specialist. And maybe it's kind of, you know, more than I can treat at this point.
Nobody understands. Nobody understands my pain. My husband doesn't understand. My kids don't understand. I thought you were the one person who understood. I had one person that cared. I wish you could spend just one day in my skin. 1 hour in my skin, you would understand how unbearable this pain is. Now I see you don't even get it. You're just trying to get rid of me, push me off on some other doctor and abandon me.
Oh, okay, I'm not trying to, I'm not trying to abandon you. I care about you. I care about your pain. Okay, I will write you an early refill this time, okay? But this is it, okay? This is the last time. Please just take it as prescribed.
I
okay?
will, doctor, I will. I promise I will.
But I'm not going to do any more early refills, all right? This is it.
I understand. It's just that with my family in town and the holidays and all the stress of that, that's all it was.
Okay.
I'm sorry I broke down like that. I know you care
Oh,
about me.
that's
I know
okay.
you really
Yeah,
do. You've
yeah.
always been great.
All right, okay.
So, I just
right.
said those things because I was scared. I'm
Yeah,
sorry.
no,
I'm
that's
really
okay.
sorry.
No, that's okay. I understand. Okay, so really nice to see you, and I'll see you next time.
All right,
Okay?
thank you.
Yeah,
Thanks
yeah.
a lot.
You're welcome. All right, take care.
Thanks, you too.
All right, bye-bye.
Bye-bye.
Okay, so hopefully you were able to observe some of the manipulative techniques as well as the defense mechanism of denial that the doctor used. The eye roll to me at the end speaks to the moral distress that I think many of us experience now as healthcare providers. The sense that the care that we're providing is actually orthogonal to the care that we want to provide. And this was obviously an example of not very good care. There were lots of potential warning signs and opportunities to intervene in this patient who may be developing an addiction at the same time that she has real and serious pain. So this was a kerfuffle that perpetuates the problem. What happens, though, when primitive defense mechanisms no longer work? For example, what if that doctor had checked the prescription drug monitoring database and could easily see that they were the fourth doctor that day or that week that the patient had seen? Then that doctor is actually de facto unmasked as a drug dealer. And when that happens, the doctor experiences a narcissistic injury. You do not need to be a pathological narcissist to experience a narcissistic injury. There's something called healthy narcissism. Anything that we invest our energy or our libido into, whether it's being a good parent or being a good doctor or being a good bird watcher, is an area in which we are vulnerable to a narcissistic injury if our competence is threatened. And this happens usually unconsciously, kind of right to the gut. And the most common reaction to a narcissistic injury is actually narcissistic rage and retaliation. toward the person who made us experience the narcissistic injury. We often don't see the link between those two. I wish I could give you an example of when I had a narcissistic injury from a colleague. I'll give it quickly. He didn't invite me to a conference to speak, and so I found myself arguing with him in a faculty meeting later and walking out of the faculty meeting and not really having any idea why I had violently disagreed with him in the faculty meeting. It took me a while to figure out that actually I was narcissistically injured by him not inviting me to that conference. So let's take a look at a kind of Groundhog Day reenactment when this doctor checks the prescription drug monitoring database.
Just one more thing before I go. Could you refill my oxycodone? I know I'm a couple of days early with it, but my family was in town this week, and oh gosh, my fibromyalgia has really been acting up.
Okay, I'm not too comfortable with that, but I'll tell you what, I just got access to a brand new database that allows me to look at all the prescriptions that you've received in the last 12 months in the state of California. So let me just look your name up on that, and you know, that will kind of help me be able to make a decision about whether or not, you know, it makes sense to do more pain meds, okay? So just give me one second.
Is that something that you can do after I'm gone? I really kind of need to get back to...
No, let's take the time. I think it's worth it to take the time now. Oh, wow. Wow, I'm surprised. It looks like you've been to see a couple of other doctors to get more opioids, and there's some benzodiazepines, clonazepam, and...
Yeah, I can explain
Wow.
that. I have a tooth abscess. I went to see my dentist this week, so, you know,
okay.
there was
This
there was a
Dr.
lot of pain.
Smith? I mean, who's the Dr. Smith
Oh,
on
Dr.
there?
Smith is my OB-GYN. You know, I've been going to her for years, and it was just time for my pap smear, so I just had, you know, I had several people I had to see this week, but
Wow.
of course you're you're the person I count on.
Okay,
you're
and
the
who's
one.
this Dr. Williams here? And there's a Dr. Jones? I mean, seems like a lot of meds going on. They're the same ones I'm prescribing.
Well, I have a medical condition that involves pain, so this pain medicine is obviously something that I need in order to manage the condition. I don't know why I feel like I have to defend myself about this.
Okay, well, I'm sorry, but I'm not going to be able to prescribe opioids anymore for you. I mean, you're obviously addicted, and I'm not going to be able to. I don't think I can actually treat you anymore. I'm going to have to ask you to leave.
Addicted? I mean, it's not like a drug addiction or an alcoholic or something. This is a medical condition. I'm getting pain medication for a medical condition. I thought I could count on you to help me out with this. This is the only medicines that help with my pain.
I'm sorry, but it is clear, you know, I had no idea that this was going on. Had I had any idea, I would not have prescribed the way I've been prescribing. So I'm sorry, I can't treat you anymore. You betrayed my trust. You broke the pain contract. I'm sorry, you're going to have to leave.
Aren't you a person who's supposed to help take care of someone with a medical condition?
I'm going to have to ask you to leave now. Okay, I have my next patient waiting. Thank you.
Okay. Another inglorious moment. Hopefully you noted the moment of the narcissistic injury. My teenage kids who have seen this video several times now walk around my house saying, I had no idea that this was going on. But also, tragically, the patient's words, aren't you somebody who's supposed to help a person with a medical condition? And sadly, what's happening is that people who have developed this problem due to our actions are being turned away. So in conclusion, how can we do better? We have to stop the pendulum. We have to stop fluctuating from the extreme of enabling this problem and also retaliating against it. So how do we intervene with any epidemic? First, there's primary prevention. We have to limit new starts of the disorder. In this case, limit opioid exposure. You all treating kids are in such an important position when it comes to limiting opioid exposure. CDC guidelines are just one example from 2016. Briefly, what you can say to patients before or instead of initiating an opioid when they ask for it. Prescribing this medication will fix your problem in the short term, maybe up to a month or more. But over time, your body and brain will adapt to the presence of the drug and it won't work anymore. Then you'll have a new problem. You'll be tolerant to the medication and experience painful withdrawal when you try to get off of it. You may even find getting off of it is near impossible. Let's look for other interventions that are safe and effective in the long term. Lots of neat studies coming out that even simple nudges, like changing the number of default opioids in the electronic medical record, can get doctors to prescribe and dispense fewer opioids. Restrictive opioid prescribing is good medicine. Lots of studies coming out now showing that after a surgical procedure, when we dispense fewer opioids, patients are not having more pain, and they're also not calling in more for refilled prescriptions. Obviously, we need to change the perverse incentives that are driving over-prescribing. I think we should eliminate patient satisfaction surveys. I do think they are orthogonal to good care. And obviously, we have to limit the influence of the pharmaceutical industry. Importantly, we have to reimburse not just for pills and procedures, but also for talking to patients, for educating them, for having a relationship with them. Non-medication alternatives for chronic pain. This is an outstanding workbook to help kids with pain without using medications at all. Remember the mind-body connection, the biopsychosocial connection. Dr. Zoffness is actually in the audience today. I'm so honored to have her here. Risk, secondary prevention. Those individuals who are at risk, how can we mitigate their risk? Here I'm specifically thinking of those individuals with chronic pain on long-term opioid therapy who are dependent. We need to assess the risks and benefits of their current opioid regimen. And if we find that the risks outweigh the benefits, we need to taper those individuals. Here's what we can say to patients. We need to taper because continuing to take opioids at these doses isn't safe, even if you're not addicted. Safety is our priority. I care about you. So therefore, we need to taper. I hear you that the opioids work for your pain, but you're probably medicating withdrawal from your last dose rather than treating your underlying pain condition. As we taper, your pain will get worse before it gets better. This is opioid withdrawal mediated pain. It does not represent progression of your underlying pain condition. HHS guidelines just came out talking about how to taper patients. They used a flowchart adapted from the Oregon Pain Guidance, which was in turn adapted from a course that we did here at Stanford, a free CME, how to taper patients off of chronic opioid using the Bravo protocol, which is a biopsychosocial approach. The message for the Bravo protocol is slow it down. I have patients on year 3 of their opioid taper. Think about neuroadaptation and how hard that is to reverse. Also, tell them what to expect. Their pain will get worse. That's not a progression of their underlying pain. It's time limited. It's opioid withdrawal mediated pain. Finally, tertiary prevention. We have to treat existing cases. Think of addiction as a chronic, relapsing, and remitting disease. Even if you don't believe it is one, it doesn't matter. In this day and age, biologizing problems is how we solve them. If we don't bring addiction treatment into the house of medicine, we're going to perpetuate the problem. Here's what to say to patients. In addition to your chronic pain condition, I think you may have developed another problem, an addiction to the opioids that are meant to treat your pain. If that is true, then you're not alone. So normalize it. Millions of patients have gotten addicted through a doctor's prescription. The good news is there's good treatment for opioid addiction, which is really true. Treating addiction as a disease in the house of medicine works. This is a seminal paper showing that when you compare outcomes for addiction treatment to outcomes for treatment to asthma or type 2 diabetes, you see robust and similar responses. It works like a chronic illness, a relapsing and remitting chronic illness. Get your X license. Use all the tools in your toolbox. I do not personally think that buprenorphine should go in the water supply like some people are suggesting, but it is a very useful tool and it really does change lives for some patients. But don't forget about your psychosocial interventions. This is kind of an era of 12-step bashing, but Alcoholics Anonymous and other 12-step groups work when patients go and when they participate and work the steps, and it works for young people. There are young people's groups. Don't forget this excellent resource, which is free and exists in every church corner, in every basement, all over the world. Of course, we need to provide alternative sources of dopamine. As Freud said, love, work, and play. I urge you to look at the Icelandic experiment where they built gyms across the country and in doing so greatly reduced their substance use problems among teens and young adults. You can refer your patients to us in the Stanford Outpatient Addiction Medicine Dual Diagnosis Clinic. We do see teens, although it's a small % of our practice. Unfortunately, outpatient psychiatry here does not take Medi-Cal, but if they have other insurance sources, we would be delighted to see them. We have a new inpatient addiction consult service. on the adult side. We're hoping to expand this to the child side. I want to give a big shout out to Tad and Diana Toby, who have given money for a youth addiction initiative. We are in the process of putting that together in our department to create resources for addicted teens and young adults here at Stanford. I want to give a shout out to Catherine Shong and Danielle Boren, who are working on an addiction curriculum here among pediatric residents. I want to let all of you know that there's a Stanford Addiction Medicine Fellowship, where after your pediatric residency, you can do an additional one-year training in addiction medicine. We would welcome those of you who are finishing up a pediatric fellowship or an anesthesia, pediatric residency, anesthesia residency. We will take anybody. We are desperate for experts to fill this workforce. You have my book. These videos are available free online. And if you have any questions, feel free to email me. I would be happy to work with you or respond to your questions. Thank you so much for listening.
That was a great tour de force. Yeah, we have time for just a couple questions. She has to leave right at 9. So, Phil?
So Medi-Cal, you have to send them to the county. There's something called Gateway, which is a number. For teens, it's much harder, but there are some resources locally, but there are very few resources for teens who don't have insurance, unfortunately.
We'll go here and then, go ahead.
What program is medical? We're dealing with staff, providers, whatever.
So the program is the well-being. What resources do we have for our faculty and staff who have addiction problems? The well-being committee is the resource. You can contact the well-being committee and they will work to set you up with a treatment provider. I'm also happy to see, I see quite a few physicians who work in our hospital. I'm happy to help those individuals if you want to contact me directly.
Can you comment on the so-called fifth vital sign that we do all the time in the hospital?
Right, so that's the Joint Commission in 2001. They endorsed pain as the fifth vital sign. They actually didn't make that up. That came from the American Pain Society, which is now defunct. But it was this idea that you could actually measure pain, and in doing so, you could improve pain outcomes. Unfortunately, there are no data showing that using that, happy face, sad face 1 to 10 scale actually improves pain outcomes. All it's shown to do is to increase opioid prescribing. So there's a real pushback on pain as the fifth vital sign, and it probably was never a good idea.
You went very quickly, but can you just briefly pinpoint screening again? Because I'm not quite sure what you're...
Right, so that's confusing to a lot of people. Theoretically, screening makes sense, but we do not have good screening tools. So the opioid risk tool, which is often endorsed, has not been shown to predict who will develop opioid use problems. So it's not to say that you shouldn't ask the questions, but you shouldn't think because you've asked the questions and somebody is screened negative that you have carte blanche to prescribe opioids and they won't develop problems, which is why the CDC guidelines recommends continued monitoring throughout the course of opioid prescribing, at least every 3 months. And what I didn't get a chance to emphasize is that monitoring must include objective data points, talking to family members, checking the prescription drug monitoring database, potentially getting urine drug screens. Because if you just rely on this interaction between you and your patient and your mutually affectionate relationship, you are not going to get to what's really going on with them. And I've been doing this work for 20 years, and I still get fooled all the time. So I'm totally humble about my ability to tell when patients are lying to me. I cannot tell. And the truth is, when patients who are addicted are lying, they don't even know they're lying, which is what denial stands for. Don't even know I am lying. Denial.
All right, we're going to end on that.
Thank you so much.